So good evening, everybody from AORA and Anesthesia TV. I'm handing over this session to Dr. Ritesh Roy, and we are online now.
Uh, Good evening, everyone. Welcome to the AURA webinar. This time, we have slightly gone deviated from the regional anesthesia aspect. Right now, the point of care ultrasound, it has evolved as a monitoring and diagnostic application in the intraoperative, in the post-operative, in the ICU settings. And since all the you have got the ultrasound machine, easy accessibility of the ultrasound machine in our OR, and you can spot diagnose just by using the point of care ultrasound about the airway, about the fasting status of the patient, about any problem in the lungs in the intraoperative or the post-operative period. So we as a regional anesthesiologist who are trained in working on the ultrasound, so we should also be knowing the point of care ultrasound aspect for the good service to our patient. So to discuss that, we have done this POCUS session in which we have got three fantastic speakers who will speak on the airway ultrasound, on the lung ultrasound, and on the gastric ultrasound. So before starting the session, I will hand over to our president of AURA, Dr. Vrushali Ponde, to welcome you all for this focus session. Over to you, ma'am.
Many thanks, Ritesh. Namaste. A very, very pleasant good evening and welcome to this extremely focused session on POCUS. I welcome you all with a lot of excitement, and I'm sure you're going to have a lot of fun listening to the brilliant minds of the Academy of Regional Anesthesia. And please don't withhold back any questions or any comments that you would want to make and ask after this particular program. Without any further ado, I would like the next speaker, rather Ritesh, to come and introduce you to all the speakers. And here we go. Thank you. Thank you for being here and logging in for our program.
Thank you, ma'am. Thanks to Fusifilm, Mr. Rahul from Anesthesia TV, who has worked round the clock for last 1 month to bring this focus session to you all. We have got our two moderators, Dr. Harshal Wagh from Mumbai and Dr. Nanshu Chakravarti from Calcutta, who will carry forward the whole session along with me. I am Dr. Ritesh Roy, and we will take all the questions. So you all are free to ask any questions, whatever you want to ask on the focus, and our three speakers are ready to answer it. So over to you, Dr. Harshal. Kindly moderate the session. Dr.
Yes, thank you, Dr. Ritesh. Thank you, Vrushali Madam. Very good evening to all of you and welcome to this webinar on POCUS. So it's a great honor for me to be part of this session where we are going to focus on POCUS. And I'm not going to waste too much time. We'll start off with Dr. Himjyoti Das, who's going to talk about a very important topic as far as anesthetists are concerned. He's going to be talking about the USG of the airway. I'm just going to quickly introduce him. Um, so Dr. Himjyoti Das is, can you see my screen on his CV slide?
Yes, we can.
Yeah, so Dr. Himjyoti Das is a senior consultant and head at the Department of Anesthesia and Critical Care at the Nazareth Hospital in the beautiful city of Shillong. And he's done his postdoctoral fellowship in regional anesthesia. He's a DNB guide. He's a regular speaker and faculty at AORA and ISOCON. And he has articles published in IGA and Canadian Journal of Anesthesia. And as I said before, he's going to talk about the airway USG and the airway blocks. So without much ado, kindly take over, Dr. Himjyoti. Thank you.
Hi, thank you, Harshal. Can you hear me? Am I audible?
Yes,
Yes, yes, yes.
Okay, I will start sharing the screen. Am I visible? Slides are visible. Hello.
Yes,
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 Dr.
yes.
Yes, we can.
Okay. Good evening, everyone. I'm Dr. Himjyoti. Thank you very much, Harshal and Bhushali ma'am, Ritesh, Arunangsu, everyone present here. Uh, this will be my second POCUS program in AORA platform, I think, after that first on webinar on the lung ultrasound in COVID. So today I'm going to talk a little bit about the airway ultrasound and some airway blocks which are very common. Before we go, I'm showing you just the agenda. What agenda I'm going to talk on. In this 30 minutes, we'll discuss airway device placement confirmation by ultrasound, the size assessment of the endotracheal tube. The third point is very important. That's the prediction of difficult airway and difficult laryngoscopy. That's very important in theater along with in emergency situation and some procedures, and finally the blocks. I'll probably touch with a slide or two with identifying some airway pathologies and predicting post-extubation stridor, which is very important in ICU setting. So I bring greetings from you, greetings from Shillong to you all. These are the cherry flower which are blooming and making the whole city Shillong pink at this point of time. I don't have any conflict of interest, and I have taken consent for photography and videos you are going to see in this presentation. And at the same time, I appreciate the help from my DNB student and one of the OT technician who volunteered their necks for this photograph that I have bought for you. Before I go into detail, I'll probably let you know about the basics of airway ultrasound. In airway ultrasound, you need to have a little bit of probe orientation because they are a little different from your blocks of the nerve. So little bit of different because you are going to not see everything here clearly. You need to identify the air mucosal interface, which is very important while doing airway ultrasound, and you need to identify the relevant structure in the ultrasound. So the probe orientation, we do the airway ultrasound in three plane. One is the sagittal plane, one is a transverse plane, and one of course is the coronal plane. The sagittal plane can be again a true sagittal or a parasagittal. I will come to that in later in the subsequent slides. So basically we are going to do three kind of scan. One is a sagittal, the transverse, and the coronal. So what we do, how we start scanning of the airway? First, we do the sagittal scan. The sagittal scan starts from the suprasternal nodes. We put the probe, is shown here. You can see the probe is placed here. The first thing what we identify in sagittal scan is the tracheal ring, that is known as the pearl of string of pearl. You can see the ring 1, 2, 3, 4 along with the cricoid cartilage. Then we keep on bringing the probe upward and we keep on seeing the structures upward from cricoid to cricoid cartilage, then to thyroid cartilage, and subsequently the hyoid bone. When we go for the transverse scan, the same way the transverse scan starts in the suprasternal nodes, the first thing we see is the tracheal ring. As a black shadow here, you can see the tracheal ring, the air mucosal interface here. Then you can see the thyroid gland here. This is the isthmus of the thyroid, that's the right lobe, that's the left lobe. If I go further higher, I get a bigger black structure, that's the cricoid cartilage. Go further higher, you will get the cricothyroid membrane. And you will start getting the sternocleidomastoid shadow very clearly. Go further higher, you will see the vocal cord with the thyroid cartilage. You can see the anterior commissura vocal cord and two erythenoids sitting on the both sides. Further higher up, you get a shadow of the hyoid bone along with the cornu of the hyoid. So this is how we scan systemically of the airway. First, we do a sagittal scan, see the tracheal ring, see the cricoid cartilage, cricothyroid membrane, the thyroid cartilage. In the transverse, you get the tracheal ring, subsequently the cricoid cartilage. the cricothyroid membrane, and subsequently thyroid and the hyoid bone. So coming to the confirmation of airway device placement, this is very important. There are some publications which shows that it takes much lesser time to confirm the endotracheal tube placement by ultrasound, and it is much more confirmatory than the auscultatory method. So here what we can see is a double line shadow. If you can see, this is the sagittal scan, the same place where I have kept the first scan probe. I keep the scan probe there. You can see the cricoid, you can see the ring of the trachea. Then you can see air mucosal interface in the first line, but you can see another bright line. That line is created by the endotracheal tube. So I am confirmed that the tube is in the trachea. You can see a double barrel sign here on the transverse scan. So if I put the tube into the esophagus, you can see there are almost same caliber as the trachea. This is called a double barrel or a double shadow sign. You can see the trachea here without any endotracheal tube, but you can see the endotracheal tube shadow into the esophagus. That means this patient got an esophageal intubation rather than the endotracheal intubation. So you can immediately confirm that the patient has got an esophageal intubation. But at the same time, if you see here, the Rayleigh tube caliber is much smaller than the endotracheal tube. What you have seen in the first slide here, the endotracheal tube gives a much bigger esophageal shadow here rather than the Rayleigh tube. You can see a smaller Rayleigh tube here, and that's the endotracheal. So this patient has got an endotracheal tube in the trachea along with a Rayleigh tube into the esophagus. So that makes it much easier for you and much less time consuming to identify where the endotracheal tube is. Second thing that ultrasound can help in the theater and in the critical care unit is the estimation of ET tube depth. Clinical assessment by auscultation and by observing the chest rate may fail to identify up to 55% time of endobronchial intubation. Plus, there are some studies which has already shown. Just a second, I have some trouble here. Okay. So tracheal ultrasound by saline, that's called TRUST, is a technique by using saline filled endotracheal tube assessment, which actually can show us the depth of the tube. If you see in this particular person, you can see the shadow of the tube here. And I have filled this cuff with normal saline. You can see this shadow of the cuff nicely with normal saline. You can see the proximal part of the cuff starting at the second tracheal ring. That's the cricoid. Usually the proximal part of the cuff going to the tip is around 6 centimeter. So each tracheal ring is around 7 millimeter in this particular patient. So I can well calculate the depth of the cuff and where the cuff tip is sitting. So it is much easier by doing a TRUST, that is called tracheal rapid ultrasound saline test, to confirm the depth of the tube. If you feel that the cuff has gone to around 4 or 5 into tracheal ring, you can well pull out the tube little more so that the proximal part of the cuff stays in the 1 or first or second ring. Here you can see the LMA been pushed more deeper into, and that LMA has gone into the esophagus. You all are aware about the position of the esophagus by now probably. That's the trachea, that's the esophagus. You can see the cuff of the LMA has gone much deeper into the esophagus. The same cuff I have pulled out little bit. Now you can see well into the trachea. So the LMA has actually been repositioned here in the second slide, and you can see the LMA is nicely positioned in the just above the trachea. So the third part of importance of doing ultrasound of airway is the ET tube size prediction. Most of the time you probably will feel, can I predict the size of the tube? These two publications, one in 2010 and one in 2013, they said it has the ability to predict accurately up to 98% of cuffed and 96% of uncuffed tube. Though it was in a series of pediatric patients, the same formula can be applied in adult patient also. So what we do is we put the probe in cricoid area and take the difference of this air column So in this image, you can see the air column is 10.7 millimeter. So 10.7 millimeter tube is roughly corresponds to your H-size tube, outer diameter of the H-size tube. So this patient I can safely put an H-size tube. So you can predict the size of the tube, you can predict the depth of the tube. These are the utilities of ultrasound in that operating theater and the critical care unit. So coming to the most important part of airway ultrasound is the difficult airway prediction. Most of the time you might end up in during the laryngoscopy that you can't see the trachea, you can't see the epiglottis, and you will be trouble. So can we predict a difficult airway by the use of ultrasound? Yes, so here we are going to discuss in three headings. One is visualization of hyoid bone. If you can visualize the hyoid bone in the submental scanning in a transverse scan, it is more or less predicted that this intubation will be easier. If you cannot visualize the hyoid bone, be alerted that you might probably be getting a difficult intubation. Next is hyomental distance ratio. I'll show you how to measure the hyomental distance ratio. The third one is anterior neck thickness and the tuck thickness and the tongue thickness to thyromental distance ratio. These are little calculative. I will give you a very simple calculation so that you can remember and can use in your clinical thing. So here you can see, because the curvature of the neck, you can put a linear probe, low frequency, curvilinear probe is essential to be placed here. You can see the mandible very nicely and the hyoid bone shadow here. So the distance from the mandible to hyoid is very well measured here, and you can actually predict this patient will give you a difficult airway or not. Coming to the second thing here, measuring the hyomental distance ratio. Here you have to extend the neck, measure the hyoid bone and the mandible, and ask the patient to make the neck neutral. Then again measure the distance from the hyoid to the mandible. This is the hyoid shadow here. And what we do here, we do a measurement from the extended to the normal neck. In this patient, if you can see nicely, in that extended neck, I got 63 millimeter, and in a neutral neck, I got around 57 millimeter. So if I divide 63 divided by 76, 57, sorry, I get a ratio of 1.1. So any ratio above 1.12, you are going to get a very easy intubation. So you measure the hyoid and the mandible in an extended neck, take the measurement, allow the patient to remain in neutral, take the hyoid and the mental distance again. Take the both measurement, extended measurement divided by neutral neck measurement, you should get a ratio of anything above 1.12. In this patient, I got a measurement of 1.1. So I was pretty sure I will be able to intubate this patient easily. Any ratio 1 or 1.05 and below, you should be aware of getting a difficult airway. I think I am clear to this point. Then is your tongue thickness and tongue thickness to thyromental distance ratio. This is very important. Any tongue thickness of 6 centimeter, you are going to get a difficult intubation. So what you can do is you can put the probe in the submental area and take a tongue impression like this and measure the tongue thickness here in the submental region. If this distance of this tongue or the thickness is more than 6 centimeter, you are going to get a difficult intubation. In this patient, I got 4 centimeter. So I'm not going to probably get a difficult intubation in this patient. Next, you put the probe in a sagittal section, sagittal plane, take the distance from the mentum to the thyroid. That is called thyromental distance. Then you take the difference, the tongue divided by the thyromental distance. Here it is 4 divided by 8.81. So this distance should be more than 0.87. Less than 0.87. We got here is 4 divided by 8.8. So we got it 0.45. So this patient was extremely easy to intubate. So I have given you 2 different calculations. One is the tongue thickness itself more than 6 centimeter predicts a difficult intubation. Another is tongue thickness divided by the thyromental distance. Here I got 4 is the tongue thickness divided by the thyromental distance of 8.8 centimeter or 88 millimeter. So I get a ratio of 0.45. Any ratio of 0.8 and above are going to be difficult intubation. Another is this publication, this in 2011, Odhikari et al., they published that anterior neck thickness at the level of cricothyroid membrane or in the periepiglottis area more than 2.8 centimeter is a better predictor of difficult laryngoscopy. You can see I have put the probe exactly in the epiglottic area. That's the epiglottic shadow. So from the epiglottis to the skin, if this depth is more than 2.8 centimeter or 28 millimeter, you are going to get a difficult patient or a difficult intubation. In this patient, we got only 99 millimeter or less than 1 centimeter. So this patient, I am not going to get any difficult kind of intubation. So this is a very easy and very simple. You put the probe in a transverse plane, just in the cricothyroid membrane, just tilt the probe little upward till you start getting the shadow of the epiglottis. Then you freeze the screen, measure the distance from the epiglottis to the skin. This distance, anything below 2.8, you are going to get an easy intubation or laryngoscopy. So the last part of my talk is the airway procedures and airway block. Airway procedures, basically ultrasound guided procedures are cricothyrotomy and percutaneous dilatation tracheostomy. This is interestingly found in multiple studies that cricothyroid membrane in an emergency situation, when you try to identify the membrane in a conventional technique, you are probably missing it around 40% of times. So it is always better to identify the cricothyroid membrane by the use of ultrasound. As I have told you, it is much easier. You can put the probe in a transverse sagittal scan in the suprasternal nodes. You can see the cricoid, you can see the tracheal ring, you can see the thyroid. Try to identify the cricoid and the thyroid, and between these two, there's the cricothyroid membrane. So what you can do, you can put a mark here in the cricothyroid membrane. Then you can go ahead with your intubation or whatever alternative. If you fail, then you need not to waste time to find out the cricothyroid membrane. You can simply go ahead and do a needle cricotomy in that particular region, which has been already marked by the ultrasound. So the same way you can do percutaneous dilatation tracheostomy. You can put the probe in a sagittal scan, identify the ring 1, 2, 3, 4. The tracheal ring 1 is always bigger. Do not confuse that first tracheal ring with cricoid. Cricoid is much bigger, but the first tracheal ring is always bigger than the second, third, fourth, and fifth. So you identify between the second, third, or the second, third, or the third, fourth, and put a mark, and subsequently you can go ahead to do it, percutaneous dilatation tracheostomy here. Coming to the most important awaited part of this presentation is airway blocks. Airway blocks are mostly performed for awake intubations, where you probably the anatomy or the situation demand an awake intubation. Here you need airway blocks. Airway blocks are not that easy block to perform. It has got a lot of failures, right? So need to learn a little bit about the airway block before you start performing it. So if you see the innervation of the airway is innervated by 5th, 9th, and 10th cranial nerves. The trigeminal nerves supply mostly the nose and the upper part of the nasopharynx. Then the glossopharyngeal nerve supplies the posterior 1/3 of the tongue, vallecula, anterior surface of the epiglottis, and superior laryngeal and the radial laryngeal, they are the branches of vagus nerve. They supply base of the tongue, and the radial laryngeal supply the larynx below the focal cord. So if you want to put a nasal tube, then probably you need to anesthetize the 5th nerve. That is supplied by the sphenopalatine ganglion and the ethmoid nerve, which is a branch of ophthalmic division of trigeminal. When you try to anesthetize the mouth oropharynx, then you need to probably anesthetize the glossopharyngeal nerve along the superior laryngeal nerve, which is a branch of vagus. And anything below that, the laryngeal opening into the trachea, you need to definitely block the recurrent. So basically, to have a airway block, you need to block at least 4 to 5 nerves. Particularly, you need to block the glossopharyngeal, superior-laryngeal, and recurrent to have a gag reflex absent. Otherwise, the moment you try to instrument the airway, patient will start coughing and gagging. So glossopharyngeal, superior-laryngeal, and recurrent nerve, these 3 nerves are essential to block for any block of airway. So there's some conventional technique we have all been used over these years for airway block. One is lignocaine gargle. You can allow the patient to gargle with 4% lignocaine. But the only thing is this gargle nebulization cannot predict 100% blocked. So you can have a failed block, then patient might start gagging or coughing during the instrumentation time. And another thing is we have all been doing all these days glossopharyngeal, superior-laryngeal, and recurrent nerve in a conventional technique. I'll show you how to do a conventional block. Then subsequent slide I'll show you how to do an ultrasound guided superior-laryngeal and glossopharyngeal nerve block. So trigeminal, as I've already told you, if you're planning a nasal intubation, then probably you need to block the trigeminal nerve, usually achieved by nebulization or packing with 4% lignocaine. You can well do a nebulization with lignocaine, 4% lignocaine, but this nebulization will need at least 15 to 20 minutes prior to the procedure. Then you might get an effective trigeminal block, or you can push in some 4% soaked wick into the nasal cavity. You can see the sphenopalatine ganglia and the isthmoid nerve here. So you can basically put the wick here for around 3 to 4 minutes with 4%, and that actually block the sphenopalatine and the isthmoidal nerve, which is a branch of ophthalmic division of trigeminal. That's about the trigeminal. Coming to glossopharyngeal nerve block, glossopharyngeal can be blocked either intraorally or styloid approach. Styloid approach is actually not recommended for OT situation. That's for basically blocking the glossopharyngeal nerve for neuralgia part of thing. You need a chronic pain. That's not for acute situation because it has got a lot of complications and it's difficult to perform. So glossopharyngeal nerve blocking orally is much easier. You have 2 approaches here. One is called anterior approach, one is called posterior approach, depending upon which part of the tonsillar pillar you are going to give the injection. If you give the injection anterior part of the tonsillar pillar, that's called the anterior approach. If you give the injection posterior to the tonsillar pillar, that's called the posterior approach. But here you need a well mouth opening. The patient need to open the mouth properly. Then only you can probably block the posterior approach. Otherwise, anterior approach is little easier. Ask the patient to open the mouth, use a tongue depressor, then anterior pillar of the tongue. You can see here, you can use a long hypodermic needle or a spinal needle, inject around 4 ml of 2% xylocaine. But be careful, lot of blood vessels are around, so keep on aspirating while giving liquids of local anesthetic. So you have to perform the same block on both sides, right and the left, to have a proper glossopharyngeal nerve block. So coming to the glossopharyngeal nerve block in peristyloid, that's the block is being done outside the oral cavity. So here you can see there's the stylus process and there's the mandible, there's the mastoid. Between the mandible and the mastoid, you have the stylus process, and exactly next to the stylus process is your glossopharyngeal nerve, but that is accompanied by hypoglossal and the accessory nerve, and is again accompanied by 2 major blood vessels, that's the jugular and the carotid. So what you do here, angle of the mandible, take 1.5 centimeter cranial and join the mastoid, the midpoint, put the needle and hit the styloid process. The moment you hit the styloid process, withdraw and go little posterior cranially. But be careful, keep on aspirating, you might enter the internal carotid or the jugular. With a negative aspiration, you can deposit around 4 ml of drug, but you cannot block the glossopharyngeal alone. You are bound to block the accessory and the hypoglossal when you try to block the glossopharyngeal in a peristyloid approach. This is a little risky procedure. It is not done that frequently, so you can always do intraoral or during the gargle. Usually this glossopharyngeal get blocked, but not completely. ultrasound guided glossopharyngeal nerve block, that is peristyloid. That is very again complicated block. It is difficult block. The same point you put the probe. Because of that body structures, you don't get a very good image, but you can see the styloid processor very clearly. You can get the mastoid, the mandible here, and the styloid. And just next to the styloid, you can see the artery pulsatile here. So you always put the color Doppler, otherwise you will not be able to appreciate the blood vessel. In the same patient, when I put the color, you can see the carotid pulsatile just next to the styloid process. So put the needle here, cross the styloid, try to keep away from this carotid and deposit around 4 to 5 ml of drug here. You will block the glossopharyngeal, you will probably block the accessory and the hypoglossal nearby. Then coming to the superior laryngeal and recurrent the branch of vagus nerve. These are the most important block for a completely gag-free intubation or instrumentation of the airway. You have all seen probably this is the thyroid cartilage, this is the cricoid cartilage, and that's the hyoid bone. So the injection is done next to the cornu of the hyoid, between the thyroid and the hyoid. That's the thyrohyoid membrane. I'll show you clearly in the ultrasound image. Here, if you give around 2 ml of drug on the both sides, you block the superior laryngeal nerve. That's the internal branch of superior laryngeal nerve. Both sides you have to give the block. Then for recurrent laryngeal nerve, you have to insert a needle in the cricothyroid membrane between the thyroid and the cricoid, enter into the trachea, deposit around 2 ml of drug. The moment you deposit drug, patient will cough vigorously. By coughing, he will disperse the local anesthetic into the trachea, which will anesthetize the sensory supply of the trachea, which is by recurrent laryngeal nerve. So you can conventionally block these two, but you cannot guarantee a complete blockade by giving a landmark technique of laryngeal nerve, the superior and the recurrent laryngeal. But this can be achieved very clearly by doing an ultrasound guided block. So as I already told you, this is the hyoid, this is the thyroid, and this is the thyrohyoid membrane. And this superior laryngeal nerve branch out into internal and external. The internal pierces the thyrohyoid membrane and enters to supply this area, the sensory supply. So our aim is to block this, not this. So in ultrasound, we put the probe in a parasagittal scan. You can see it is not pure sagittal. I have gone into little lateral. In parasagittal scan, the moment I put the scan, I can see the thyroid cartilage here very clearly. You can see the hyoid bone shadow here. You can see a black big muscle, that's the thyrohyoid muscle. Below that will be the thyrohyoid membrane. So bring the needle out of plane as I have already shown here. Put the probe little lateral to the midline. Try to identify these structures. You're bound to see these structures. Try to identify the thyroid cartilage and the hyoid bone. Between that, you will see the black muscle, that is the thyrohyoid. Try to identify the bright structure, that is the thyrohyoid membrane. That's the airway coming again down. So here you bring the needle out of plane till you cross the thyrohyoid membrane. The moment you cross the thyrohyoid membrane, deposit around 4 to 5 ml of drug here. The drug will disperse here and will block the superior laryngeal nerve. That's the internal branch of superior laryngeal nerve. Coming to the last slide of my presentation, identification of some second last slide probably, identification of some AORA pathology. Those are most of the time are accidental finding. You can see a vocal cyst in the vocal cord here on the right side of this patient. That's not significant for our interest, but this is important. Most of the time after the thyroid surgery, the ENT surgeon will ask you, can you see the movement of the vocal cord? It's very difficult to put the patient on a laryngoscopy and ask the patient to make a sound to see the vocal cord movement. Rather than doing that, you can put the probe in the transverse plane in the thyroid cartilage area and allow the patient to make a E sound, and you can see both erythroid moving very close to each other. You can see the cord is opposing very nicely. That means this patient doesn't have any cord palsy. If you have got a cord palsy, this erythroid will not move and will not oppose like this. You can see both erythroid opposing very clearly here. Cords are coming to the midline. So this patient doesn't have any palsy. So if you have got a palsy, you can identify this side or this side, this cord is not moving to the middle side, and you can probably tell the surgeon that this patient has got a right or left-sided palsy. The post-extubation stridor, can we estimate post-extubation stridor? Air column weight difference of more than 1.6 millimeter to be taken as to predict post-extubation study. How to do that, I'll show you in this slide. Measure the air column in the cricothyroid membrane area. This is patient with an endotracheal tube with cuff on. You can see a squarish kind of shadow. That's the cuff is on. I have measured with cuff on 0.82 centimeter or 82 millimeter. Same patient, I deflate the cuff. The moment I deflate the cuff, you start getting a trapezoid kind of shadow. So you know this is a deflated tube, cuff deflated, this is inflated. So here I get 10.3. So difference of more than 16 millimeters. So this patient, if I extubate, I'm not going to get any kind of stridor in this patient. So you always measure the air column difference when the cuff is inflated, measure it, deflate the cuff after doing a suction, then again take the measurement of the air column weight and take the measurement and see the difference is at least 16 millimeter and above. If it is so, you are not going to get any post-extubation stridor. So to conclude, usage of upper airway ultrasound is useful in airway management because it is very portable, it is non-invasive, it is cost-effective, and you can repeat it whenever you want. It doesn't have any kind of exposure problem or anything to the patient. You can keep on repeating. Ultrasonography of the neck can accurately localize the cricothyroid membrane for emergency airway. As I have already told you, you miss around 40% of them when you try to localize the cricothyroid membrane only by palpation method. So it is always better to use the ultrasound to identify the cricothyroid membrane for emergency crico. Airway ultrasound is very sensitive and quick assessment tool for prediction of difficult airway and device placement confirmation. I have already told you, at least you can measure the epiglottis to the skin depth. Anything above 2.8, you are going to get a difficult intubation. Airway blocks are preferentially used in planned difficult intubation. In an awake patient, biopsies are done. For diagnostic endoscopies, these blocks can be used, but some of these blocks are potentially dangerous. So airway nebulization of spray may be considered if ultrasound visualization is difficult. And that's not the block for novice. Please keep it in mind. Particularly, parastyloid glossopharyngeal blocks should not be tried if you are not very comfortable giving other blocks. Thank you, and I'll be ready to take probably questions.
Thank you, Dr. Himjyoti. I think Dr. Hitesh will take questions at the end of the session. Is that correct?
Yeah, we'll take the questions at the end of the session.
Yeah,
Okay.
thank you very much for that talk. Excellent presentation, very nice videos, and it was a great talk. Thank you, Dr. Himjyoti.
Thank you very
I
much.
think I'll pass on the mic to Dr. Arunanshu. Is that correct, Dr. Hitesh?
Yeah.
And take it forward.
Yeah.
Dr. Arun. Yeah.
Yeah. Okay. Dr. Himjyoti, can you stop the screen sharing?
Yeah.
Okay. Our next speaker today is Dr. Amit Dixit. You can see the handsome guy sitting with a pink shirt. Okay. So I'll just briefly introduce him to Dr. Amit. Dr. Amit Dixit, he is a consultant anesthetist at the Ruby Hall Clinic in Pune. And he is a course coordinator of postdoctoral fellowships in regional anesthesia under Maharashtra University of Health Sciences. He is a regional anesthesia fellowship of AORA coordinator also. He is a member of the Board of Studies, Fellowship and Research Committees of AORA India. He is an executive committee member of AORA, of course, and he is also a peer reviewer of Indian Journal of Anesthesia. He is an executive committee member of Pune Regional Anesthesia course. He is a PG guide of DNB. He has keen interest in regional anesthesia and POCUS. He has contributed a chapter in regional anesthesia practical handbook, and he has published articles in index journals, AORA newsletters, and ISA newsletters. So, Dr. Amit Dixit is going to speak on basics of lung ultrasound. Okay, over to you, Amit.
Yes, thank you very much, Arunanshu, for those kind words. Yeah, once you stop it, I'll share. Thank you. So at the outset, I would like to thank Team AORA for providing me this fantastic opportunity to work with Fine. Can you see this? Yeah.
Yeah, make it big.
Yeah. Is it
Yeah,
visible?
yeah, yeah,
Yeah, it's
perfect.
visible. Yes, visible.
Well, thank you. So thank you very much. I'll be speaking on basics of ultrasound. This topic is very close to my heart. I am really happy to speak on any topic related to POCUS. When it comes to Ruby Hall, I'm fortunate that in our infrastructure, our setup does provide good ultrasound machine. We have 4 dedicated ultrasound machines with our institute, and they have all 3 probes. We have a fellowship program going on, and our fellows do enjoy all these value addition information regarding POCUS. I'm grateful to Brushali madam, I'm grateful to Harshal, Arunangshu and Ritesh for providing me this opportunity. I would like to start with this book. Disclosure is, I mean, I have gone through various books. This one book I found was very useful. So somebody who is really willing to start and embark on point of care, this is a very good book to start with. I have gone through this book very thoroughly. So my slides are influenced by this book. I have used some of the images. As far as videos and other images are considered, I have taken permission from my patients. Now, coming to lung ultrasound, if you look at lung ultrasound way back in 1990, people thought that lung ultrasound is just not possible. Why it is not possible? Because lung is full of air, and air is big no for any lung ultrasound. So it was in disrepute till for the first time Professor Daniel Lankinston, he's considered as pioneer in this area, and where he showed few images which was which were very useful. Many protocol like protocol and other protocols are initially first few articles were from Professor Lankinston. So what is the POCUS application? Why we should go for POCUS? Is it one more fancy gadget and we want to play with it? No, actually the evidence is much more in favor of use of POCUS, because it has a very high speed and accuracy of diagnosis and testing. It is really very fast. And why we want to use point of care is because we do not wish to delay onset of, the gap should be very less between onset of symptom and initiation of definitive therapy. Think of a situation in your hospital where you want to use POCUS. Say for example, a patient is desaturating in recovery, and now you are looking for X-ray technician and things like that. If there is hypotension, you are looking for some monitor. So whenever you talk of point of care, you delay, you actually reduce the onset of symptom and initiation of definitive therapy. So it is very fast. So when it comes to lung ultrasound, is it related only to lung? I think no, because in my department, in our institute, we practice holistically. POCUS is point of care ultrasound. So already Himjyoti has covered with the respiratory element, but unless we have taken good care of care at intubation, we have avoided aspiration risk, lungs cannot be protected. If there are hemodynamic issues, lungs are definitely going to get affected. So we must have good knowledge of other aspects of POCUS as well, which is like heart ultrasound, gastric ultrasound. So we need to know other aspects as well. So what is beautiful thing about POCUS is we have one question. We have one question to answer. It's a simple question. My patient is not maintaining saturation. Now this is the question and I need answer. Please guide me. Now I do not wish to wait for definitive treatment, some investigation. I want it right now, right here. So this is how the POCUS has some answer in form of yes or no. Say my patient is hypotensive or my patient is breathless. So we can narrow down the differential diagnosis and start the definitive management very quickly. So if I have gone through many articles, I have looked at different journals, I have looked at different websites. Most of the websites, because of COVID, are full of lung ultrasound information. There are many evidence-based articles which says that it is very useful, it reduces complication, useful in pleural effusion, cost is less, radiation is less, extravascular lung water is picked up very well, recruitment maneuvers, pneumothorax, so on and so forth. So you can have many more indications. Now I'm talking about limitations. Like if I have to start POCUS in my institute, what are the issues? First is, this is a global issue, training and credentialing. It is even today, it is on the basis of CME. It is on the basis of e-modules, e-learning. There are limited availability of portable ultrasound is another issue with different institutes. Also, there is resistance from some specialties like cardiac, some or maybe intensivist, radiologist, something like that. So these are some of the limitations which we have to look at. Now, what is the evidence? Now, evidence, as I was telling you before, evidence is much ahead. Actually, training part is lacking behind. Evidence is much more ahead. If you look at the evidence-based literature, you can easily understand that ultrasound is far more superior than chest X-ray, whether it is pleural effusion, pneumothorax, consolidation, or interstitial lung syndrome. When it is X-ray and CT scan, yes, they are almost equivocal. So it has reached to a level of CT scan. And in some cases, it is ahead of CT scan. I'll brief you later. So what are the evaluation areas? Different people use different ways. Like somebody would say anteriorly, it is divided into two, laterally again two, and posteriorly again two areas. So basically there are three areas: the anterior, lateral, and posterior. So I would like to follow what Lankenstein has done. And Lankenstein has now, this is a published article, and in which they have narrowed it down to 3-point anatomic examination on one side. So it is either it is on one side, it is upper lobe, middle lobe, and lower lobe. So basically you look at anterior, lateral, and posterior. So basically three areas on one side and three on other side. So this appears logical and it can be easily done. You can go through blue protocol, and how this basically is the protocol. If patient is breathless, then we have to narrow down the diagnosis and find what is the cause. So this was the original paper with blue protocol, and here it is anterior, lateral, and posterior. So three areas on one side, three areas on other side. Basically we are looking at these three areas: anterior, lateral, and posterior. Now different ICUs and who they are doing regular follow-ups, they have their own institutional protocol, and in which it may be 12 zones, it may be 14 zones, it may be 18 zones, it may be 21 zones. And every time in that individual zone, they will note down the changes, and they will thereby know whether patient is improving or not improving. So you can follow your own protocols. Now, use of probes. If I'm doing adult ultrasound, curvilinear probe is the best because it provides a big window. Linear probe, basically I would like to use for pediatric patients, and also when my interrogation is limited to pleura or diaphragmatic thickness. The phased array probe or the echo probe is very useful because you can play in between ribs and you can get rid of ribs. This probe basically I use for diaphragmatic excursion and PLAPS point that I will show you. So basically diaphragm movements are better picked up. So there are multiple articles. I mean, you talk of different specialties. This was with Vincent Chan, who said indication, acquisition, interpretation, and decision making. The same protocol you follow for point of care lung ultrasound. Then everyone must have read RAPM article on lung ultrasound. So regional anesthetists are following it very closely. We find that multiple articles in cardiothoracic journals, and they are also very much into prognostication and diagnosis as well. Even in pediatric cardiac surgery, there are good number of articles. Most of them are recent, after 2016-17. You can also see ICU, the whole variety of ICU literature full of lung ultrasound. And with present COVID, you will find many articles on COVID as well. So who is actually the in charge of lung ultrasound? I think if your anesthesia is patient centric, I think everyone can use it. Now, what I am going to show you today is some bit of pattern recognition. So tomorrow when you are entering in your OT and looking at all these patients, you will have some idea. So what I'll be showing all these A lines, B lines, lung point. I have photos and videos. So this is one scanning video which is our volunteer from OT. So preferably we do it in semi-recumbent position or sitting position. This is a curvilinear probe, and that is how I am scanning for the anterior scan. You can do it bilaterally. You can go in above, the upper and the lower interspaces. And what we are looking at is a normal scan, a healthy volunteer. So what is normal scan? We are looking at a pleural sign. So pleura is moving. So you can see the pleural movement, and below the pleura there is A line. So all these A lines and sliding sign of lungs, this is normal thing. So similarly, the same thing can be done in lateral position. If at any point of time you find some problem, you find some artifact, you find some issue, so immediately you can rotate the probe, make it transverse, and try to adjust your probe in such a way that you are in between true ribs. Otherwise, as far as scanning is considered, it is all to and fro movement, and you keep on scanning, and you have to wait at least for 6 seconds in one space to identify that. So this is how you scan. If you find some pathology, you focus on that, make it transverse, and jot it down. So this is about the lateral. Similarly, you go for the posterior side, and on the posterior side, it is you have to go higher up, because the viral infections and higher areas do get affected. So you have to scan even up to T1 and T2, that area. Majority of the posterior area is blocked by the scapula, so you have to work in that area. So we'll be covering each aspects further. So little bit about A lines. Basically, when you put an ultrasound probe 90° to the patient, what you see is a reverberation artifact, and there is air and no fluid. So you all see this. This is A line, and this is perfectly normal. Now, what is lung sliding? Now, in a healthy lung, there is visceral pleura and a parietal pleura. As patient is breathing, they tend to move, and it produces a lung slide. Sorry, it produces a lung slide. So if you could see this lung slide, I'm playing the video. You can see the pleura is moving, and this movement of pleura is called as lung sliding. Now, if you are able to see the moving pleura, that is enough. No need to put M mode. But if you have any doubt whether it is moving or not moving, then to pick up all those fine movement, you can put M mode. M mode is basically for temporal resolution. It is in relation to time. So when you put an M mode, then all along the M mode, you will have all the motions picked up. So pleura, if pleura is moving lower down, you will see sand, and deep inside is a sea. So it is something called as seashore sign. Now, what happens if there is absent lung sign? Absent lung sign. Absent lung sign means once you put the probe and you see this picture, and now there is no movement. So the differential diagnosis is not pneumothorax always. Pneumothorax is one of the possibility, but we have to look at it. So it could be pleurodesis because of various factors. It could be loss of lung volume because of mucus plug or something, or it could be absent ventilation in that area because of silent chest, severe COPD, severe asthma, or it could be endobronchial intubation, or it could be DLT placement and one side not getting ventilated. So absent sliding sign is very, very important. This is if you know A lines and sliding sign and you can elicit it correctly, I think 50% of the job is done. Now, what is the importance of sliding? Lung sliding is, if you see lung sliding, it has got 100% specificity that there is no pneumothorax in the area of interrogation. What about B lines? Now, B lines are also artifact. These are reverberation artifact, but these are not curly B line. Curly B line you see on chest X-ray. These B lines you see on ultrasound. What are these B lines? These B lines are straight vertical laser-like lines. It is because of the increased water content in the sinusoidal in the lung fissures. Now this is a new machine with our institute. It is when you go, and it has got score, B line score. So it will automatically detect how many B lines are seen, and this is auto B line. So it will tell you if it is above 3, then it is, and then you are worried. So these are the confluent B lines which start from pleura and they go distally. So you will read about the description. You can go through, a vertical laser like, and starts from pleura, go by far, and then if you are interested in pursuing it further, then how they are different from E line and Z line and things like that. But basically, you need to pick up this pattern of, this is basically increasing water content of the lung. So water content means it is not pulmonary edema all the time. Even if patient has lung contusion, it will be increased water content. So any consolidation, any pathology of the lung will first manifest as B lines. So it could be cardiogenic, non-cardiogenic, viral. So B line means pathology. So this is when there are multiple B line, you need to know how they look. So what is interstitial syndrome? Interstitial syndrome is when you see bilateral multiple B lines, two or more positive interspaces bilaterally. So what is a positive interspace? When you have more than 3 B lines. So you need to know, because we need to differentiate whether it is bilateral or unilateral. In viral pneumonias, it is patchy unilateral. They are bilateral starting from pleura. It could be cardiogenic pulmonary edema. If pleura is thickened, it could be non-cardiogenic pulmonary edema. So basically it is increase in water content, and you can see this graph here is fluid and air, and as the water content is increasing, it is going up to ARDS. So initially we were not seeing any line, only A lines, and then B lines have started appearing, confluent B lines, and then pulmonary edema and ARDS. So different scoring systems, I was already mentioning your ICU protocol you can follow, and individual segment you can follow, and you can prognosticate with use of this. So there can be pulmonary edema. As an anesthetist and perioperative physician, I am very much worried about perioperative pulmonary edema. So I'm giving you 2 brownie points for pulmonary edema, because we are dealing with point of care ultrasound. So whenever you have pulmonary edema, everyone wants to give fluid. Always do subcostal 4 chamber to see IVC. And if it is a pediatric patient, then they do either IVC aorta ratio, or they go for VTI, velocity time integral. So these are the ways by which you can initially know how much is the fluid, and then you can give Lasix and plan your strategy. Another brownie point I am giving you is bladder assessment. The fluid and hemodynamics is not completely assessed unless we look at bladder. So once we have given Lasix 100 milligram and there was no urine, because urinary catheter was blocked. So always make this important point is to note that bladder is full, and urine is being passed. So when we are giving Lasix, now another important point, are the ureters functional? So I'm putting a Doppler here, and you can see jet of urine coming from right ureter. And also if you wait, you will see on from the left side also. So this is a pulsatile flow, so urine is getting formed and it is getting drained. So you are very sure how point of care is providing you opportunities to look at it. Our renal transplant team is very happy with this demonstration. Now I'm coming to pneumothorax. Now we have managed fluid and fluid balance, and we have saved our lungs. Now pneumothorax is a very common problem. And what is the pneumothorax is actually there is a visceral pleura and a parietal pleura. So visceral pleura is actually moving, but because of air between the two, visceral pleura is just not visible, and you see only the parietal pleura. So that is how what we see in pneumothorax is there is no movement, because down is air and you don't see any movement of air. Visceral pleural movement is not seen. So this is something, when we put an M mode, it is called as barcode sign or stratosphere sign, because nothing is moving. And this sign is useful in predicting, but I have already informed you that absent sliding sign has multiple differential diagnosis. So what is the pathognomic sign of pneumothorax? One is these are absent B lines, absence of lung pulse, presence of barcode sign, but most pathognomic is lung point. Lung point is the point where the normal lung and the lung affected by pneumothorax meet. And if you could identify this point, then it is very, very pathognomic. Now, this was my patient last week. Patient had malignancy and patient has undergone CT guided lung biopsy. So whenever biopsy was done, there was edema and there was pneumothorax, which we have already seen on CT. I thought I will just pick up on ultrasound as well. So you can see this is pleural lining and pleura is moving only half. Can you see the movement of pleura? Pleural movement is not complete till the end. So you will see that pleura is moving only partially till this area. I'll just show you again. So pleural movement is only half, and this remaining half of the area is just not moving. So this is the lung point, and if you can see this lung point, then you are very sure about pneumothorax. Now, what is the importance of PLAPS point? PLAPS point is a posterolateral aspect where we look for consolidation, atelectasis, pleural effusion. So never miss this point when you are doing lung assessment. So what is consolidation like? It is lobar hepatization. I'm not going into details, but this is how the picture appears. These are air bronchogram, and this is lobar hepatization. Then what about atelectasis? There are different types of atelectasis. Again, I am not going into details. Here is a pleural effusion and there is volume loss. If you have atelectasis, even with recruitment maneuver, you can see that this segment is improving. So with ultrasound, you can do many things. Coming to pleural effusion, yes, I am giving little emphasis on pleural effusion because we deal with it on a day-to-day basis. Ultrasound can detect as little as 20 ml of pleural fluid. And when it comes to X-ray, it requires almost 200 to 500 ml. So here pleural effusion is very well picked up. Ultrasound, the evidence when compared with chest X-ray and auscultation, it is very much ahead. Now I'm talking about CT. CT is always considered as gold standard. But when it comes to complex pleural effusion, where we have septae, where we have exudative fluid, so exactly the nature of complex pleural effusion, it is said, now this is a published article which mentions that it is better appreciated with ultrasound and not with CT. Because with ultrasound, you can see above and below the diaphragm, and you can look at what is exactly happening, and you can plan your strategy. How much pleural effusion? Because we have to induce a case, so we should know by and large roughly how much is the pleural cavity filled with. So this is a basic formula. So you have to calculate distance between parietal and visceral pleura and multiply it by 16. There are different formulas. One with Balic is multiplied by 20. And it gives more or less the same value. So you have to calculate, drop a caliper and just see and multiply it. Now the rule of thumb is if it is more into 2 or 3 interspaces or distance is more than 10 centimeter, definitely fluid is more than 1 liter. But when to put any tube or something? When the distance between parietal and visceral pleura is at least 1.5 centimeter. Because if it is less than 1.5 centimeter, it means you can damage the visceral organs. And always put a color Doppler, because intercostal vessels bleed very heavily. Try to approach all these pleural effusions 6 centimeter lateral from the spinous process, because within 6 centimeter from the spinous process, the intercostals are heavily present and leads to bleeding. Lung recruitment, I was mentioning, with atelectasis, you can expand the lung. Now I'm coming to a very important aspect, which is diaphragmatic assessment. This has not been done that well, or because people think it is very complicated. So it is done with phased array probe, and I'm sure everybody will like this, the explanation. So there are 2 aspects to diaphragmatic assessment. One is excursion and second is thickness. So excursion, where we will be doing, it is between mid-clavicular line and anterior axillary line. So keep this point as a fixed point, because every time everybody is putting probe anywhere, that is not right. So you have to fix this point, and you will see the diaphragm movement. And as the diaphragm is moving, you will see excursion. So this is inspiration, expiration, inspiration, expiration on M mode. So you can measure the difference between the point with highest peak and the point with depression. So this is how we have done here. Now that was with silent breathing. Now here I have asked to do voluntary sniff. So he's breathing very heavily. So voluntary sniffing, you can see much more depression, and you see how the diaphragm is moving so fast. So you have to do it when the patient is silent as well as sniffing. So when it is sniffing, the distance increases, the peak and the depression, they have changing very fast. So what is the normal value? With quiet breathing, the difference between inspiration expiration on M mode, it should be 18 millimeter, and with voluntary sniffing it is 26 millimeter. So anything less than that, you are worried whether I can extubate this patient, whether this patient require ventilatory assistance, whether my block has still keeping the muscle paralyzed. Another aspect is diaphragmatic thickness. Now this has to be done with linear probe, and with linear probe the thickness has to be measured at end expiration, which is usually 1.8 to 3 millimeter. So how you do it? You do it in a very systematic way. You put the probe near mid axillary line, where the dome meet. So you can see lower down here is the diaphragm. It has 3 layers and the diaphragm is moving nicely. So you have to put an M mode, and as the patient is inspiring, the thickness of diaphragm increases. As he expires, with expiration the size decreases. So you have to again calculate the difference between inspiration and expiration. So you can see how it looks. So at inspiration it is 36 millimeter, and at exhalation it is 21 millimeter. So you have a formula for that, and the formula is thickness at end inspiration minus thickness at end expiration upon end expiration. So if it is like here, it is 36 minus 21 upon 21 into 100. So if that value is more than 20, it means diaphragm is very well functioning. If it is less than 20, then probably probably that phrenic nerve is paralyzed, or there are, if it is bilateral, then issues like amyotrophic lateral sclerosis, muscular dystrophy, polyneuromyopathy, and things like that. I am not going into details about viral pneumonia, but yes, with COVID, you can easily pick up. The results are equivocal with that of CT scan. What are the important things with any viral pneumonia are, patchy areas of distribution of B lines. It may not be bilaterally symmetrical, irregularities with pleura, thickening of pleura, and subpleural consolidation. So you have to grade these patients, and in later stages they'll end up with ARDS. Now, small word about pulmonary embolism, because it is very important for us. Actually, the pulmonary embolism is diagnosis of exclusion when you have A lines, normal sliding, and still patient is tachypneic. So we need to work out why patient is having this problem. So the diagnosis of pulmonary embolism is, you have to look at heart, you have to look at leg for DVT, and you have to look at IVC. So I'm just showing the femoral here, and you can just see if femoral vein is compressible. Now here you can see a clot, but if femoral or popliteal vein is not compressible, then there is a problem. Another brownie point which I would like to give you is, get yourself acquainted with at least basic FATE protocol, so that you can generate images for RA and RV. So at least if you can identify that there is no RA-RV dilatation, or they are doing here it as a ratio. So what is the ratio? Ratio between RV and LV. Ratio between RV and LV, if it is less than 0.6, it means the RV is not dilated. But if RV is dilated, then the ratio is more than 0.9. So here it is a 4-chamber view. Actually, you can put a very nice TAPSE here, the tricuspid annular plane excursion. Here I can identify that right ventricle is actually RV function is very good. You can put a color Doppler. If there is pulmonary embolism, you will see PA pressures and things like that. But at least eyeballing will help you. Now this is parasagittal short axis view. So you can see the papillary muscle, mid papillary plaques view. So short axis view. So here you can see left ventricle and that's the right ventricle. So you can put a caliper and draw the line and you can measure the diameter and you can identify the ratio. So this is very important when we are talking about pulmonary embolism. So what are the differential diagnosis when you have a normal lung scan? You have looked at all the areas, but patient is breathless. Then one, it could be pulmonary embolism. Go ahead with CT angiogram and VQ scan, because point of care may not be able to pick up all those, subpleural consolidation within zero 0.5 centimeter and things like that. So it could be metabolic. Am I dealing with diabetic ketoacidosis? Is it neuromuscular, or it could be psychiatric? Lastly, I'm summarizing my talk with a demonstration, and I think we have already seen up to the areas where we have seen A line and also the plural sliding sign. Now, further, we have already covered it, and in the summary, I'm just showing you once again. So here is the phased array probe, and I am keeping it between the almost near mid clavicular line. So it is between mid clavicular and the anterior axillary line, and I'm trying to look at the posterior aspect of diaphragm. This is the posterior aspect of diaphragm because it is stronger, it has better contractility. So you have to put M mode there. Probably I need to increase the depth, but you can put M mode there, and you have to consistently elicit this view all the time so that you can, pre-op, post-op, you can compare. So here you can put an M mode and you will see inspiration and expiration. Probably, see, this is inspiration. I probably had to increase the depth, but anyways, you can understand here that's the inspiration, expiration. So after freezing, you can identify this is inspiration, expiration. So like that, you have to put again and measure the difference between them. And if it is this is quiet breathing, so if it is more than 18 millimeter, then it's normal. Now I am going to Plaps view, where I am looking for the diaphragm, the consolidations, the pleural effusions, and you can see the diaphragm nice. Get above side of the diaphragm is the lung. Below below you will see liver, because I am on the right side. So you will have a mirror artifact. If there is pleural effusion, you will have positive spine sign, and so you can see very well that there is no pleural effusion, no consolidation in this area. So you cannot complete your examination unless you have looked at this area. So with this, I come to my lecture, ending my lecture. Whatever information we are gathering with ultrasound, of course, it cannot replace clinical judgment. I acknowledge various websites. I have gone through different e-learning modules. Some of the images I could use from them. And as far as patient images, I have taken full permission from them. I would like to express my gratitude to whole of my department who helped me in generating these videos, including my RA fellow. I am really happy about it. Thank you very much for patient listening. Before I conclude, if you are interested in POCUS, then we have two CMEs coming up, one on 20th December, it's on pediatric POCUS, and another on 4th December, it is by ISA Guwahati. It is on obstetric POCUS, and we will be discussing a very focused session on that. And last but not the least, AORA fellowship is going on, and interview dates are in the month of December. This is flyer from my institute, Ruby Hall Clinic, Pune. Another is from Hetal Vadera, Rajkot. And the last one is from Ritesh Roy, Bhuvaneshwar. So if you are interested, please visit, please complete the formalities and join. Thank you very much. Thank you indeed.
Thank you very much, Amit. It was a really wonderful presentation. You can stop sharing your screen now. And I will invite Dr. Harshal. Harshal, are you there?
Yes.
Yeah, to introduce our next speaker. Thank you.
Yes, thank you, Dr. Anancho, and thank you, Amit. That was a really great talk, and it's always a great pleasure to listen to your talks. Great learning. Thanks very much. Uh, It's my pleasure again to invite the next speaker, who's going to talk about again an important topic as far as anesthetists are concerned, and it's about gastric anthem, USG of the gastric anthem, and it's my pleasure and honor to introduce him for the next talk. So he's Dr. Subramaniam Mahankali. He is an alumni of AIMS, and he's also been a consultant in the UK. So he has vast experience of working in India and the United Kingdom. Can you see the slide which I'm sharing actually?
No, you have to start screen share. Your slides are not slide is not visible. Yeah.
Visible now?
No, not yet. Yeah.
Yeah. So let me start.
Now I can see the slide.
Now you can see. Yeah. So my pleasure to introduce Dr. Subramaniam Mahankali, who is going to be our next speaker, and he's going to talk about ultrasound of the gastric antrum. He's an alumni of AIMS, and as I said, he's been also a consultant in the UK, has vast experience working in India now as well. He has been on the editorial board of many reputed journals like the JACP and the IJCA. He is a faculty at many national and international workshops and conferences, with more than 20 publications to his name, and he's also written many chapters in textbooks. He's a senior consultant in the Department of Anesthesiology at the Astravi Hospital in Bangalore. And it's my pleasure again to introduce Dr. Subramaniam Mahankali. Please kindly take over. Thank you.
Thank you, Dr. Harshal.
I'll just stop.
Am I audible?
Yeah, you're audible.
Thank you. At the outset, let me thank the team AORA for giving me this opportunity to be with you all. On the screen, what we have is a few places to whom I'm quite indebted. The one is AIMS, where I learned most of my basic skills and some of my advanced skills as well, and fine-tuned quite a bit of it at Queen's Medical Center, Nottingham. Now, when normal people see just trees, experts can see forest and garden. I don't know whether most of you have seen this gentleman or not. We all fondly call him Kumar sir. He is one of the pioneers of use of ultrasound in Bangalore, in Karnataka, perhaps in the entire nation. I remember, when discussing with him, maybe around 2013-14, he came out and said, we have been using ultrasound for a few years now. It is going to find applications, and he had just scanned and found a publication in RAPM about anesthesia analysis, about gastric ultrasound. Said yes, we should learn those skills. And how true was he that this was a publication which had come at that time? Then we thought, why not scan and see whether we can do it and take it further, etc. And that led to the scanning of one of the volunteers who was here, and to see if we can identify the stomach and follow whatever is mentioned in the book. And to our surprise, we could find, yes, there we can do the gastric ultrasound fairly easily. The next thing was we got ourselves involved with the radiology team to learn a little bit more how exactly to go ahead, etc. And that led to doing a research in our department in Columbia, Asia, when I was working there. And that led on to a 2-year study in which we studied nearly 100 peri-operative patients to see how empty the stomach is or how full they are. And that led to publication of this. And now, after nearly 4 or 5 years, we see that it is gaining recognition now. That means even in the current NPO guidelines issued by the ISA, we have a comment on gastric ultrasonography, and it says that gastric ultrasound may be used as a bedside tool for assessing the quality and the quantity of gastric contents in the perioperative period. The quality and the quantity of gastric content should be assessed in the right lateral decubitus. Let us go in detail and see what we need to do, how easy or how difficult it is. We have been very fortunate in that way that anesthetists senior to us, or those who have studied NSF for a long time, they have made it very easy that any difficulty which we face, they have tried to stratify them. They have to start. There are stratifications for airway difficulties, coronary events, post-op pulmonary events, stroke, DVT, name it. Most of them have been stratified, and we have now reached a stage in which we can easily communicate with the other people what is happening, whether it is easy, difficult, or if difficult, how difficult it is. And all this, what it means that we can use the risk reduction strategy. We can mitigate the risk and use strategies to reduce the risk. And one area till this focus came around was even not being using these methods objectively in detecting whether a patient is prone for pulmonary aspiration or not. We have just relied on patients' words for figuring out fullness of the stomach. In this age and day, when we have so much access to technology, we can do more than just this. Besides patient's history, if we look at the patients of the category of patients which are coming, we have a huge number of conditions which cause delay in the gastric emptying. Diabetes, only 1 in 3, maybe 1 in 2 patients coming in have CKD, sepsis, chronic pain. All of these conditions, they have do affect the gastric motility. In effect, they affect whether the stomach is full or not, in spite of fasting. On top of which, we have patients coming with pain and trauma, which delays the gastric emptying. And also, we find patients on a number of medications which can affect the gastric emptying. Now, majority of the hospital institutes are slowly starting to have this ultrasound machine. All we needed was to use these machines which we have at our bedside to see if we can assess this part. So all we need is these machines along with 2 probes. I'll go through in detail, and we can perform a gastric ultrasound which can aid us in multiple ways. Fundamental to our understanding of gastric ultrasound is understanding a little bit of anatomy and physiology. When we consume food, the food we eat goes down and settles at the dependent area. And the dependent area, in the sense, is if you divide stomach into fundus, body, antrum, and the pylorus, most of the food what we eat goes and settles down at the bottom here. There, the mixing of the solids and liquids happens. Food stays there for long. If you put most of the emptying happens last in this area, and this area is of interest for us to the gastric scanning. There have been attempts to do the other scans, but this seems to be the most appropriate area, most suited for doing a gastric ultrasound scan. Besides that, we not only want to see whether it is full, we also want to see whether it is empty, how it looks. This area of the stomach, gastric antrum, has a typical appearance on an ultrasonographic image. We will see later on how this looks like. The typical 5-layered appearance is there, which we are able to identify when the stomach is empty. Because we not only want to see when the stomach is full, we also want to see and assure ourselves it is empty, and what we are seeing is actually the gastric antrum. Basically, as I was telling you, the important landmarks when we are trying to identify this part of the gastric antrum is, if you look at the picture on the left, you have the left lobe of the liver here, you have the colon here, and behind that, if you look at in this picture, you've got the liver, you've got the stomach, you've got the pancreas here, and duodenum and bowels here. So, and you can also see the aorta here. This is anterior and this is posterior. You can see when you put a probe here, we should be able to get a cross-sectional view of what is behind that probe, what is happening in the deep. When we put an ultrasound on the patient, when we're doing bedside, actually, what we see is you have to scan, you have to put your probe slightly just to the left of the midline in the epigastric area and move the probe slowly towards the right. And I'll tell you the landmarks where you have to stop and analyze and take the pictures and imaging. So what, in a sense, when you're doing, if this is what we're doing on the epigastric, deeper to it, what we're scanning is basically we are trying to move from just to the left of the midline to the right and identifying the gastric antrum. This gastric antrum, pyloric antrum, is the most important part in our gastric ultrasound examination. What settings we need, what probe we need to use? In most of the large adults and large pediatric patients, we need to use curved probe because it can go as deep as what we want, even though most of the times it is 3 or 4 centimeters deep from the skin. A lot of times we will find it around 6 or 7 centimeters, which when we are using a linear high frequency probe, it is not possible. In small children, we can use linear high frequency probe. All we need to do is do a scanning the epigastrium in a sagittal plane from slightly to the left of the median to the right in the subcostal area. You can mark out this epigastric area, start from the right, start from the left, slowly scan towards the left. You need to do scanning in two positions. One is the supine and right lateral. This is the standard recommendation. Of course, you will have patients who cannot turn laterally. In those patients, we can give a slightly head up or a semi-recumbent position and can do scanning at this part, in this position. Now, when you put the probe, when you put the curved probe, this is what you will see. As a norm, what is generally done is the left of the screen is always the cephalad and the right of the screen is the caudal. So when we put the probe, this is what we are likely to see. What happens is initially you will find that there is nothing visible there, but if you follow a systematic pattern, you will be able to see all this what you can see now. If you go systematically, you can see the skin there. Deeper to the skin is our subcutaneous tissue, the rectus muscles there, the liver is isoechoic, and then you can see the pulsation of the aorta, and you can see most of the times you have to stop at the way you can see the superior mesenteric artery. You'll be able to see the bowels, you'll be able to see the pancreas. Sandwich between the liver and the pancreas will be our gastric antrum. This is a wonderful, easy landmarks to see, and it is, believe me, whether whatever the size of the patient, it is possible to see 99.9% of the cases. When I saw the first video, we were not able to recognize. Now in the second video, we showed went systematically. Now in this video, you can see even though there is no coloring of it, we still can see skin, subcutaneous tissue, the rectus sheath, the liver, the pulsations of the aorta, SMA is going there, aorta SMA. You can see the bowel shadow here, the pancreas, and this shadow is caused by the pyloric antrum or gastric. Is it clear now? Go to the next slide. Now we have identified how to go and identify the gastric antrum. After identifying, what should we do? This is the commonest thing which we have. Yes, we are seeing it, but there are three kinds of assessments what we can do. They're called as qualitative, semi-quantitative, and quantitative. Qualitative in the sense that you look at the picture to analyze whether it is a solid, it's a liquid, or empty. Quantitative, obviously, it says by its name that you quantify exactly what is the content in there. You can assess the residual gastric volume by using the quantitative estimation. And semi-quantitative is when you can't do quantitative, you don't have access or you are not using, but just want to have a gross scan and see the volume is significant enough or not. That is about semi-quantitative. I will go to it a little bit more detail as we go through. Now, this is the sort of picture that you will find if you put a probe and you find that the liver is here. You can see the pulsation of the SMA. When the stomach is empty, you will see that both the walls of the mucosa are touching each other. As a result, it's completely empty here. This is the picture of an empty gastric antrum. Now, when you have clear fluids in the sense it could be water, it could be non-particulate clear fluid, something like a pre-carbohydrate drink, etc., in which the image appears hypo. This is the gastric antrum. Inside it is your hypoechoic, or maybe slightly hypoechoic picture. That is how a normal clear fluid would look like. Whereas if you have solids, the picture changes here. Again, systematically liver, aorta, SMA, and the stomach is completely dilated here. The gastric antrum, you can see bigger. You can see it is because it is bigger picture. The depth also is more here. It is more of an isoechoic or sometimes hyperechoic spots are there. This is the classic picture of a full stomach with solids. Now, I was telling you about qualitative assessment. Qualitative, in essence, we want to see whether the stomach is empty, or they contain solids, or they contain fluids which are either clear fluids or milk suspension. Depending on that, the picture what you get is dictated, and you can grade the stomach whether it is grade 1 or grade 2. I'll come to this grade 0, grade 1 in the next few slides. Now, this is how classically you would find an empty gastric appearance. So where in which the antrum is flat and collapsed and round to overt look appearance with that. People call it bullseye or target shaped appearance. In essence, there is absolutely no space between the two mucosas. They are approaching each other. Sometimes there may be small space, that is fine. That is not a problem. It's not too much to cause any problem for us. So another appearance is if there is any solid remaining in that part of the stomach, then the solids can usually blunt the ultrasonic phase, and you will see a comet trail appearance. This is the blurring of the posterior wall. You don't have a clear definition of the posterior wall because of solids in the antrum. This is an empty stomach. This patient was fasted for more than 8 to 10 hours. In this, I told you about qualitative assessment. What is semi-quantitative? Now, in the qualitative, they're looking at just whether it is empty or it contains solids or liquids. If there are solids or thick fluids, you always consider them as high risk. I will come to that recommendation again. If it's empty in both the positions, when you scan in both supine and right lateral, you can read it as clearly safe. But if you find there are clear fluids, there's clear fluid in the gastric antrum, now you go out to see whether the fluids, what we are seeing, is present only in the right lateral position or in the both supine and right lateral. If it's present only in the right lateral position, that means there's a 75% chance that the volume in the stomach is likely to be less than 100 ml. Usually, if you take an average person as 70 kilos, less than 1.5 ml per kg, close to that, so it is usually safe. If the fluid is present in both supine as well as in the right lateral position, then you should place the patient in a high risk category for aspiration. That is, there is a 75% chance that they can have residual gastric volume more than 100 ml. This is the semi-quantitative assessment. You have still not assessed exactly what is the volume. There have a number of studies, a number of equations given to do how to do quantitative assessment. Now, quantitative assessment, how to do? So again, you take the same picture. Now, once you have identified the picture, make it go still, and you put most of the ultrasound machines have a tracing tool. If you use the tracing tool, some of them are free, and you can have an ellipse as well. And you can put a tracing tool around the gastric mucosa, around the gastric serosa, and you can estimate what is the cross-sectional surface area. This entire thing is cross-sectional surface area. Once you get the cross-sectional surface area, this was the first and probably the most popular model given. When you get a cross-sectional area, you can feed into this formula here, where you can get right lateral cross-sectional surface area, and the other component is involved in this age. These are the two variables in this mathematical model given. This is perhaps the most popular model to use to quantitatively estimate what is there in the stomach. Okay. Now, how to measure the cross-sectional area? I showed. You identify the antrum, obtain a still image, use a free tracing tool, obtain the cross-sectional surface area, and put it into the equation, put it into the model. You will be able to get what exactly is the estimated gastric volume. In that way, you can say what is the approximate amount. Now, what is it? How to do? Again, if you have a patient, you have a stomach which is filled with either liquids or solids. If you see solids, the first step, which of the qualitative assessment has found solids, you need to take additional precautions. In case if it is liquid, this is when you want to proceed with volume estimation. So what you do, you identify it, you identify the entire circumference of the gastric antrum, and you use a free tracing tool and obtain what is the cross-sectional surface area. Once you get the cross-sectional surface area, usually if you trace it, you will get something like area is 16.6 or whatever it is. You put that whatever we have obtained cross-sectional surface area into the equation to obtain the actual gastric volume. This way you can do the volume assessment, that is estimating the amount of residual gastric volume. So what is the significant number? Is there any cutoff? What is generally accepted now is if the volume left in the stomach is less than 1.5 ml per kg, you are probably in the safe zone. If your estimated volume in the stomach is more than 1.5 ml per kg, that means probably there is an increased chance of aspiration. It doesn't mean aspiration will not happen. What it means is there is an increased chance of aspiration. You take additional precautions. How to use this information? I will come back to it again. There have been a number of nomograms developed. For my personal use, I have devised a calculator using an Excel power sheet. If you want, at the end of the program, or if you request, send an email to me, I can share this calculator. If you put these two measures, you can easily estimate what is the volume. If you know already the weight, it's very easy to calculate what is the residual gastric volume. Now, in effect, so far, from what we have studied, there are 3 steps of examination. You have to examine the patient in supine and right lateral position. If you find First is the qualitative assessment. That means you see whether what is there in the stomach. Is it empty? If it is empty in both the positions, take it as grade 0. The next thing which can be there is solids. If it is solids are there, take it as high risk. Take all the precautions to make sure that stomach is empty before you proceed, or take precautions to proceed with whatever obligation you have. If you find you have clear fluids, then you can proceed with semi-quantitative assessment. That means again scanning in both the positions, checking whether you can see fluids in only right lateral or in both supine and right lateral. If it is there in both supine and right lateral position, then there's a good chance that the volume is likely to be high, which can pose the patient for aspiration risk. And if you want to actually be precise, you can go ahead and do the volume assessment using the equations or models given by especially people who have worked in Toronto. They have given a wonderful model which has only 2 variables, that is cross-sectional area and the age, and estimate the volume using that equation. If the volume is greater than 1.5 miles, it is showing a red flag there. If you have volume less than 1.5, probably you have a green flag there. Now, that formula has been quite validated in most of the adults, including those in morbidly obese patients. But there have been people have adopted this in almost all the other age groups as well. Now, it is not, as I was telling you, it's not only adults, even in children it can be done, but the only difference is in children, instead of using a curved probe, you can use a flat probe, a high resolution probe, in which you can get an even further greater images of this. So in this image, you can see this was a gastric ultrasound scan done a 1-year-old baby before the start of the surgery. Now you can see here, the liver is clearly marked out here. You can see the gastric antrum, which is shown. I wanted to show you this gastric antrum, how it appears. The serosa is this part here, the white thing. This is the muscularis propria, and the mucosal folds you can easily see here. The mucosal folds are there. In the next slide, you will see as with the peristalsis, the mucosa comes in contact with each other and dilates. This is the characteristic appearance of the gastric antrum in a 1-year-old baby. Now, apart from using it in normal adults and babies, there have been equations which have been given, models which have been given, how to estimate the gastric volume in the pregnant ladies as well. Of course, the qualitative assessment still remains the same, but what they have come out is instead of having 2 variables, they have tried to work out whether can we do with 1 variable. And this is a very good variable in which if the suggested cross-sectional area is more than 9.6 in the semi-recumbent position, there is possibly high risk. That means if you want to do an urgent resection, you want to take them for urgent LSCS, then you can do a quick scan, measure the surface area, and instead of going to a calculator, etc., you can have a quick assessment in your mind. This is high risk, so I need to take more precautions, etc. There have other formulas also been given, in which you measure the diameter in both the in 2 different dimensions, and that can be fed into a formula to obtain the gastric antral volume. In short, so far what we saw so far is the gastric ultrasound is a powerful diagnostic tool. You can use it to examine the stomach, what is the content, and see and to grade that there is aspiration risk or not, there is increased or not. The findings are easily recognizable and examination easily done, and can be used in all the age group and sexes, including those with morbidly obese patients. What slowly happened is today is a session day for POCUS, and is gastric ultrasound. What is a point of care tool? Is gastric ultrasound fit into the criteria of point of care tool? A tool or a device or how you use it can be called a point of care tool if it is used for a well-defined purpose and which can improve the patient outcome. And to see if there's any focused and goal-oriented, is that what you're practicing? The findings, are they easily recognizable? And the examination, can it be easily learned? Can it be quickly performed at the patient side? These are the 4 clear tick boxes which need to be ticked before you can call them a very good point of care tool. If you look at the gastric ultrasound, it satisfies all the 4 criteria. It is a limited examination of the gastric content. You can examine the type, you can examine the volume, and The goal is to prevent pulmonary aspiration. Therefore, it's being focused and goal directed. It can be performed by most people who have some experience with ultrasound machines. They have given a number of 33 scans, but I feel the learning curve is even quicker. If you have somebody who's experienced with you, who can teach you this art, it can be acquired fairly quickly. And with an accuracy of more than 90%, you can do the assessment, especially the qualitative assessment is fairly easy. It is hardly, with the 10 examinations, you can start to pick up the skills. Now, Amit showed you briefly how, when we have a powerful tool like this, how to use it. Should everyone be using it for every case? Then that becomes a big medical legal landmark. So that should not be the case. So as a result, they have given an ideal framework in which we can use this as a point of care tool. And this IA framework, it seems to be a wonderful framework to use it. It involves I for indication, A for acquisition, I for interpretation, and M for medical decision making. The indication for this is fairly straightforward for most of us. When you have a patient who cannot communicate to us, when somebody who has not followed an NPO orders, or you have an emergency or urgent procedures which cannot wait for the usual NPO guidelines by all the societies. When you have such patients, or maybe somebody's not in a condition to communicate to us because of medication or for some other problems, when you have such a situation, you can use this as an indication to assess what is the status of the stomach. That is the indication. Now, acquisition, I would run through all those, how to use the machine, how to use the probe, the positions to use, etc. All these are part of the acquisition. That is how you acquire. Probably if you can come to one of the courses organized by AORA or other places, you will actually have a hands-on feel. And when you're scanning, the most useful position is the right lateral decubitus position, the right lateral position. If you want to do scanning in one position, that would be that. In case if you're not able to do supine and right lateral, then you can use a semi-recumbent position, because when you're in semi-recumbent, all the contents come down to the lower part of the stomach. The air goes up. It will make it visible, but the best position is probably the right lateral decubitus position. Interpretation. The second half of my presentation was more about interpretation of these images, qualitatively, semi-quantitatively, and quantitatively. And if you want to estimate, you can go ahead and estimate if that gives you satisfaction. But it has to be systematic. If you first do a qualitative, see whether you have solids, liquids, or empty, then semi-quantitative, and then go on for volume. Because volume, we want to be accurate, but it can be a few percentage this way, that way. And the important part is medical decision making. Now, are we using this tool to just as a tool to have power with us, or to use it for improving the patient outcome? When you assess it, you can use it to decide whether it is the right time to proceed for the surgery and anesthesia, or delay or cancel. You may not be able to cancel or delay a lot of times. If you want to proceed, decide what is the technique you want to follow. If you are, once you decide the technique, if you need a GA, then probably you can take additional precautions to ensure that the aspiration chances are minimal. This is how the IA framework would help us from indication to the decision making. Before I conclude, these are a few images which I want you to gather. Keep it in your brain. Probably this will be on YouTube. You can access those images and see how each appearances are there. This probably will be more useful than my entire talk. Now, the first thing is gastric ultrasound done in how you see the stomach when it's an empty state. Clearly, you can see here, this is scapula, this is caudate, the liver is there, the stomach, the gastric antrum is completely flattened out. You see the flattened out up into the stomach. The next picture is when you have a patient who has consumed fluids. There is some gases is there. This is how you would probably see when you have fluid mixed with some air bubbles. This is what called as starry sky appearance. Now, when the food has been there for some time, we know we call it a chyme, and that causes a frosted glass appearance in this image. Now, now this is a gastric ultrasound image obtained from a 1-year-old child. You must be using a flat probe or a high resolution probe, which you will be able to see all the folds, and it is closely just below the liver. You will be able to see. And this was an image which I obtained in one of the patients who had come for a degestion. He was quite septic, and in spite of fasting for significant duration, the stomach was still filled with contents. Here this is stomach contents, what was just adjacent to the liver here. Now, now, this was an interesting image which I had obtained in a patient with a small bowel obstruction, wherein which the stomach was dilated, the antrum was dilated with the fluid coming all the way into the stomach, and he was a high risk for aspiration. And to last but not the least, this is a sequential scanning in a volunteer. I have scanned in the way such that you see the empty stomach and then slowly go on as you see. Now, this was a patient, this was a volunteer who had fasted for more than 8 hours. If you follow the nomogram, skin, subcutaneous tissue, the rectus sheath, the liver, I will probably play the video again here. You can see the aorta, the SMA. I can see this gastric antrum here. There's probably you can see typical appearance where the mucosa is touching each other, and they may not be a very small amount of content is there. This is the classical appearance after 7 to 8 hours of fasting. Now, the same patient, when I turned right lateral, when I was scanning, when we turned right lateral, you can see slowly the fluid starts to appear in the gastric antrum. There is a minimal fluid when asked to turn into the right lateral position. This is fairly normal. You can see it is just 2 or 2.5, 3 centimeters deep in this adult. Fairly good image to see. So this was after fasting for 8 hours. Some clear fluid is there in the stomach. This is what you expect in a patient with normal gastric secretion. This is probably basal gastric secretion. Now, this volunteer, I asked him to have a carbohydrate. We have recently started procuring pre-carbohydrate drink. And this patient, when I asked him to, I'll play the video again. When he consumed, while I was scanning, you can see the fluid is slowly entering into this part here. This is in the supine position. You can see the fluid is coming in. This is the typical appearance when he's having the drink. The next image is when I asked him to turn to the right lateral decubitus, you can slowly see that it is entering into the stomach. There are some air shadowing which is happening because the air is also going as we drink or eat. So this gastric antrum is expanded. The aorta is still staying the same. The image is almost the same position as what we did before. This is the appearance of how it would appear when he is consumed and put into right lateral position. He had consumed around 200 ml of fluid. Now, after a few minutes, you can slowly see the stomach, the gastric antrum, all the fluid is entering the dependent position. It is slowly getting dilated. You can see it is a fluid because you can see the movement of the fluid there, clearly moving from one direction to other direction, and it is almost hypoechoic rather than hypoechoic. It is hypoechoic, and some spots of you can see the starry sky appearance, moving fluids, etc. Now, after 5 minutes, you can clearly see that it has settled down now. Clearly, there is a clear settling of the fluid there, and most of the areas is hypoechoic, suggesting that it is a fluid. It's a classic where if you want to estimate volume, it's a very good case to see how it is coming up. Now, after a few minutes, I gave him some curds to see how the appearance changes, and you can see once the curds are given, there are areas where in which slightly hyperechoic are there, and the movement of the liquid is very less. Only in one corner, the mixing is happening. So it's a classic appearance when you have thick fluids, something like curds are there in the stomach. Now, this volunteer, he was quite fond of masala dosa. He went and had a masala dosa and came back after half an hour in the canteen. And when I scanned, the appearance had completely changed here. You can see, again, it's the same area, but you can see the stomach, this depth is more, a little bit more than this, because I wanted to see clearly. You can see the entire gastric antrum is dilated, mixed with hyperechoic spot, characteristic after chewing, etc. You will see that this is in the supine position. When same patient volunteer is just turned right lateral, you can clearly see there is the hyperechoic food-like appearance is there, chyme appearance is there in the gastric antrum, with some movement because of the peristaltic movement in the stomach, in which it is trying to start the process of digestion. Now, if you want to estimate, as I was telling you, you can estimate the volume, but if you are finding solids, there's no point estimating because it should be considered as high risk. And this is an interesting case which I did a few years back. This is a child who had come after accidentally ingesting a safety pin, And when I scanned his stomach, this is what I found. This is the liver. This is the stomach. What we're seeing here. This was, in fact, what we had was the child had consumed Maggi noodles. If anybody asks me how a Maggi noodles looks under the ultrasound now, here is the image for you. Now, before I conclude, the key point is the gastric ultrasound is a powerful and effective point of care diagnostic tool. It's quite focused, goal directed, and you can examine the stomach and the contents and determine the pulmonary aspiration risk. It helps us the planning of the anesthetic management and airway management. Findings are easily recognizable and examination easily run. It's fairly accurate and reliable. These are my acknowledgements. If anybody wants to have questions, I want to have a chat, they want me to read their images, you can use this contact to come back to me. Thank you.
Thank you, Dr. Subramanian. That was a great talk. It's always a pleasure to listen to your talks. Dr. Ritesh, are we to take questions?
Yeah, we can take questions.
So I think if I'll start, Dr. Aransho, is that okay?
Yeah, sure. Why not?
I got a couple of questions for Dr. Himjyoti. I think you combine the questions into one. I think the two who are asking about assessment of tracheomalacia on the airway USG. Is that
yes, Marshall, I actually didn't touch that point. Yes, you can well assess the tracheomalacia in ultrasonography. I didn't touch that part, thinking it to be too long. Usually the tracheomalacia is assessed again, putting the probe in a sagittal scan and see the collapsibility of the trachea. So ultrasonography is a very sensitive tool for assessment of tracheomalacia. Of course, that can be definitely done. Another question has come about that coronal plan, including Hattel. Actually, that photograph was a little confusing to you all probably because the photograph was taken from above down. The coronal plane per se, you take it like that if patient is supine, and if I put the probe exactly parallel to the floor, that's coronal, as simple as that. So what parasagittal is that I have shown you the probe position for the superior laryngeal nerve block. That's where is the parasagittal. Right. You put the probe in sagittal, then you tilt little bit, that become parasagittal. To make it coronal, you make it completely parallel to the floor when patient is in supine position. I believe I have answered it to Kartik and Hattel.
Right.
And there are two questions about the tracheomalacia. Yes, it can be definitely measured, the tracheomalacia in sagittal scan of the trachea, as I have shown you already in the sagittal plane. That can be done, yes.
Himjyoti,
yes.
I have a question for you.
Yes.
Basically, in thyroid surgery, basically we were talked about doing a leak test before extubation. Same as leak tracheomalacia post-thyroid surgery.
Yes.
So with the tube in place, can we detect that this patient trachea has been involved and we should not extubate this patient?
You can probably look into that airway column weight. I have already shown you. You can measure the airway column in an inflated cuff and deflate the cuff and see the difference. Right. Any difference of more than 1.6 is equivalent to around 300 ml of air leak. So you can see it in your ventilator. Put the cuff, look at the ventilator setting, the inspiratory tidal volume, the expiratory tidal volume. Deflate the cuff and see that inspiratory and expiratory tidal volume difference. So it is measured. If you have got an air column with difference of more than 1.6 millimeter, 16 millimeter, it should be equivalent to around 300 ml. So it can be done. It can be done.
Okay, thank you.
Yeah, I had one question, not a question, rather an observation for Dr. Himjyoti. It's if you could tell us about, like we're hearing today ultrasound as point of care for airway, but these are all for diagnosis. If you tell us about the, therapeutic tools like percutaneous dilatation in tracheostomy or needle physiotherapy using ultrasound, and how you do that, like in plane, out of plane. Could you tell us, our audience?
By doing an airway procedure like percutaneous dilatation tracheostomy or cricotomy, real time is difficult because you have to put the probe and you have to do the procedure. It's same like doing an epidural. So the role of ultrasound in doing PDT or cricothyroidotomy is that you identify it, mark it, then you go conventionally. But the point is identifying the cricothyroid membrane in an obese patient. If patient is 130 kilo, come with a difficult airway, you will not be able to identify the cricothyroid membrane conventionally. So what you do, use the ultrasound, put the marker, put a probe exactly in that, then you put the mid of the marker up a probe and put a mark, then you remove the probe, remove the ultrasound, then you do conventionally. That is what I do personally, yes. And I'll recommend most of you to do accordingly, yes.
Excellent. Okay, Harshal, do we have any questions? Any more questions for us?
I do have some question.
Yeah.
Hello, Himjyoti da.
Yes,
This is for you.
Yes.
Yeah. So I wanted to ask about thyroid surgery and vocal cord movement. So can we assess it
I have already told you.
without
I have already
putting
told you.
laryngoscope?
Yes, I have already told you and showed a video also. You can definitely do, but don't allow the surgeon to put the plaster yet. The moment he put the plaster over the surgery incision site, you will not be able to put. Let him finish the stitch, put enough of jelly, put the probe exactly in the thyroid cartilage, and try to see the vocal cord movement. That's very well can be seen. I have already shown you the video. If both erythroid are coming closer, the cords are coming to the midline, there is no palsy. If one-sided cord is not coming to the midline, that particular side is probably has got a paralysis. So one. Otherwise, immediately after the extubation, if you put the laryngoscope, there is a high possibility patient will gag and might vomit. So that can be avoided. Just put the plaster. Do not put the plaster. Tell the surgeon. Put enough of sterile jelly. Put the probe and tilt the probe upward. As I have already shown you, put your probe in the thyroid cartilage, tilt it little upward. Then you start getting the anterior commissure. The moment you see the anterior commissure, look down for both erythroid and the vocal cord and look at the movement. Have I answered it, Hatal?
Thank you, Himjyoti da.
Yes.
You do it before extubation, right?
Yes. I started doing it before extubation.
And maybe you can also use betadine instead of jelly, like if the surgeon doesn't want to put jelly on the, you can do it with betadine.
You can.
One small comment I want to make. When it comes to ultrasound guided airway assessment, I think it's good idea what already Himjyoti has shown to inject saline into the tube. Yeah, so the hypoechoic nature is very good. And another thing which I have came across, this was interesting finding, that when we are assessing ET2 placement in pediatric patients, say with ultrasound, we require no ventilation as such. Whereas when you are doing conventionally, we need to give at least some one blast to have that EtCO2.
Exactly.
But if you are putting the probe directly, so we can think of those cases where we just do not wish to ventilate, and we can get away with this situation.
And it's much faster to confirm that tube placement. It's much faster. Yes.
Yes. So I mean, Himjyoti, like for the difficult airway cases, if we put this protocol of ultrasonic assessment of the airway as a standard protocol, suppose for an example, when we are going to do for a front of neck access, in a difficult intubation scenario, when your patient is hypoxic and you have failed to ventilate, failed to intubate, in those situations, getting the ultrasound and locating the landmark at that point of time may be difficult, maybe impossible.
Exactly.
So what if we adopt a strategy that we point the major landmarks before going for the intubation?
I have already mentioned it in my presentation that see, most of this airway situation is anticipated prior.
Right.
I have an obese patient. I have a patient with a retracted jaw. So I anticipate already. In those patients, you do the pre-operative or pre-anesthesia ultrasonography as a tool that is incorporated into your pre-anesthetic checkup. So you do balampatti, you do lemon, whatnot. At the same time, if you have that access to the ultrasound, do an ultrasound of the airway, measure the thiomental distance, the tongue thickness, and put it down in that PAC note. That this is what. And I'm going to anticipate a difficult intubation or difficult airway in this patient. That is how it should be incorporated in, not in an emergency situation that
and you can also possibly mark the landmark like the cricothyroid membrane.
Exactly. If you really find difficult, then you can
Dr. Shukla, there is a question for you on the chat box which says gastric ultrasound view is better in the right lateral or left lateral position. That's okay.
Thank you. I'll take the question. The fundamental concept while doing the gastric ultrasound is whatever is there in the stomach, you want to get the contents to a particular part of the stomach. The gastric antrum or the pyloric antrum is dependent and slightly to the right. As a result, the best spot to make all the contents in the stomach to move to that place is right lateral decubitus. It has two advantages. When you keep them dependent for a minute or half a minute or a minute, all the contents, even if they are at different places in the stomach, they come down and settle there. The second advantage is whatever air is there, it moves out of that space. As I said, if you put a probe, if you put it initially, you may have some gastric air in there, which is obstructing you. If you put it right lateral, the air goes to the other side, to the non-dependent side, and makes it visible. This has been the standard in this case. And what is important to understand here is, one is to get an image, qualitative assessment, fantastic. But what is also is when you put right lateral and measure the cross-sectional surface area, it has got a linear correlation with the residual gastric volume. So right lateral is the position of choice. In case if you're not able to turn, the compromise, especially in pregnant ladies sometimes, etc., or other patients with trauma, is you can give a semi-recumbent, that is half head up. That means again it is going to be dependent position. The solid and liquid contents come in there, the air moves out, helping you get the images which are of high quality. I hope I answered the question.
Dr. Subramaniam.
Yes, yes, Dr. Ritesh.
Yeah, there's a question for you, and I'm very happy that this question has come from one of our fellows. He's a fellow of Harshal, Dr. Senthil. Any alternative for gastric ultrasound in a patient who has undergone a gastrectomy, total gastrectomy?
Now, these are the few limitations. Now, there are a few other techniques which have been used. The MRI is the one. If you want to take your patient just for assessment, you can go for an MRI. There have been the other techniques in which paracetamol and a few other indicated dyes have been given, tagged with paracetamol to see if there is absorption, emptying, all those things. But you cannot call them the point of care tool.
Exactly.
Yeah. Dr. Subramaniam, I have one question for you. Basically, it's from a different perspective. It's from the palliative care perspective. For our oncology patients who are like emaciated, in the palliative care, sometimes we do percutaneous gastrostomy. Now, the question is, what is the role of ultrasound in performing a percutaneous gastrostomy? Can we do it with a linear probe in a thin patient? There are some studies, gastroenterologists have already started doing it. In Mount Sinai, from Mount Sinai, they have published a series of 31 cases. And so what is your opinion about that?
People who have studied gastric ultrasound for various purposes, one is they want to find a place where there is air or no air. So far we have concentrated to a place where there is no air. That means you can get a good image of the content in the stomach. But when you want to do a gastroscopy, so you want to be doing in a space where there is no content, where there is more air, the stomach is filled with air.
And possibly a place where the liver is not on top of the stomach, like but the stomach is mostly subcutaneous, right? You're not going to injure.
Yes. What also you can use it is you can use a scan from the skin to the stomach to see if there are any vessels there, if there are any abnormal tissues there, if there is any abnormal adhesions, etc. You cannot see inside the stomach, but all the way till the stomach you can see and assess. And that way you can make it safer for the patient. Even when a normal endoscopic guided PEG tube, if you see, they will put a light to the stomach and say, oh, this is what you're seeing there. Instead of just seeing the red light coming there, so you can have an ultrasonic picture, identify the area where you want to put the needle, and then go on for dilatational or PEG tube. That's what
right. Thank you.
Actually, I had a question which is open to all. Actually, anybody can answer. Where are we placed medico-legally in terms of diagnosing and treating, say, either a lung issue or esophageal intubation or a gastric USG and has or doesn't have an aspiration? In terms of medico-legally, is that how we are placed? I think all three of you or anyone can answer. Is that?
Yeah. Should I?
Amit can take the
Yeah.
question.
Actually, this is not the problem with India. This is a global problem. When it comes to POCUS, as I have already mentioned in my slides, there is problem of challenges in the areas of training and credentialing. So, if you look at the certification process to be somebody called as a POCUS certified, these are usually the local I mean, something like ISA in India can do that, or AORA, as we are going ahead with value addition courses and all like that, we are going ahead. Now, another important is the important aspect is remuneration part. Now, so why the other faculty members like radiologists or we or cardiologists, we are not competing with them as long as we are not charging the patient. So as far as documentation and medical legal thing is considered, it is helping me to excel my anesthesia in the safer interest of patient. So if I do an ultrasound, if I do cardiac ultrasound, I put it on the paper that limited echo study suggestive of. So these are my findings. So I am not authorized to do it, but since I have done it, it can be beneficial to someone. So I'm putting it on paper that limited ultrasound study suggestive of these findings require clinical correlation or to be referred to for further investigation. So what we have found with use of point of care ultrasound is on that given moment, if you are available and if you are trained, then you can save that life. Actually, it comes to boils down to that level. So if you have an ultrasound nearby, you can actually save lives and you can manage it very well, whether it is pulmonary embolism, cardiac tamponade, or anything. So I think there is no harm because all physicians are allowed to use, and anyways we are PCP NDT certified
So
when
I
we are.
was that was probably my next question is
Harshal, if I answer that your question from a different perspective, like from what Amit said, see the spirit of point of care ultrasound is not, we are not going to give a certificate, or we are not going to give radiological radiological result of a patient that this is a gastric ultrasound. I found this. We're not doing that. What we are doing basically, we are basically aiding our own clinical practice. We are for suppose for an airway, we are just going to aid our own the process of assessing the airway with ultrasound as an adjunct. So you can use anything as an adjunct, and we're not giving any certificate for this thing. For I have done this and that, and not giving any printout and signing on that with registration number. So whatever we are doing on a point of care ultrasound is that we are using it as an adjunct for our own decision making on my own practice. So I don't think medical legal problem comes there. So, like what Amit said, and in our institution also, we are doing currently we are doing this thing. The one particular thing about echo, screening echo. Sometimes a patient gets admitted without having the echocardiogram done, which was advised in the PSC. So what we are doing is that if the surgery is emergency, we need the echo to be done. But we do the screening echocardiogram and we put a note on the patient's file, not as an echocardiogram report like a radiologist or cardiologist would give. We just write on the patient's file that a screening echocardiogram got done for the purpose of assessing the patient's this thing for preoperative reason, and this was our finding. Just note it.
Actually, I would add one thing. The purpose by definition, focus is you have one question with you and you want the answer yes or no, like that. My patient is desaturating or I have hypotension. Tell me. So we are anyways not looking at the larger perspective of the given condition. So that is why they have this PET protocol, fast protocol, and so many protocols are coming up so that you can deal with them in proper time, and that the time wasted on investigating and starting the definitive management is still further not delayed. So point of care is at that point we are doing some interrogation, and it is limited to that point where what is the problem. So like
Yeah,
that.
Dr.
So,
Dr. Subramaniam, Dr. Subramaniam.
Dr. Subramanian.
The medical legal news is all around us. So in systems which are highly litigative, for example, let's say you've done central venous canalization. After doing a cannulation, it is become a norm to do a lung ultrasound to show that there is no pneumothorax. And believe me, the packs will come into our ultrasound systems, wherein which you can save the image and say this is clear. If pneumothorax develops later on, it is not because of what has happened. So it will be coming. I'm sure it will come. Even for other things also, once it is connected to the packs, you can save those images. It will come. But other thing which medical legal which was asked is, I was part of the panel with the ISA to see if gastric ultrasound can be recommended as a standard of care. But we have not reached a stage wherein which it is available at every nook and corner of the country. It will take a few years before we can recommend, yes, you have to use it, but it is suggested as a useful tool to use if you have access. And slowly, but not surely, now we can see almost everyone is doing central venous cannulation with an ultrasound. Everyone is doing nerve block with an ultrasound. These skills will pick up. It's just a matter of few years wherein which you will do all those things fairly regularly, I feel.
Great. Thank you.
Can I ask one question, Ritesh?
Yeah,
Do we have
ma'am,
the
please.
time? Yeah.
Yeah, ma'am, please.
So I was wondering, when you were doing ultrasound guided blocks, so can we assess pneumothorax right then and there?
Yes.
And after what duration of time after a block, if we are suspecting one, or should we do it as a routine scanning to eliminate, because in all these years of practice, I don't remember having, even we were doing landmark, when we were doing USG, any patient developing clinical pneumothorax. But subclinical or radiologically, ultrasonographically detectable, does it carry any value, and should it be done?
Yeah. So yes, that was a very fantastic question. And actually, we are following this practice that when we do this above clavicle block and say interscalene block, the two areas which my fellows are very much keen on assessment is diaphragm and second is pneumothorax. Of course, our intention is safety of the patient. So if you have slightest doubt, it is, I think, good idea to scan it. Just like in my video, the patient which we have shown has undergone lung biopsy, CT guided lung biopsy, and there was a CT evidence of lung, pneumothorax there. We have documented it. It was minimal and it was under close observation. So you can, if that is how much big it is, and then it's a multi-speciality management that who will decide up to 1/3 we can still manage conservatively looking at the other parameters of the patient and so on and so forth. So basically, what ultrasound has changed our practice is we know what we are dealing with. Previously, we were not aware what is going to happen and there were surprises. So before leaving the operation theater or before patient is shifted from recovery, I would like to know how bad is the phrenic nerve palsy, or how, if there are any respiratory issues, so would like to scan. So I think it's a fantastic practice. We must scan it at the end, and even if the procedure is for a longer duration, I would like to see if there are B lines. If patient needs catheterization, we do bladder scan. So we always do this combination in our day-to-day practice.
Okay, so for pneumothorax, when we're doing above the clavicle blocks, which area would you like to scan? The anterior part?
Yes, the anterior aspect of the chest, usually. Yeah. So yeah.
Shall I briefly add a word or two for that, ma'am?
Yes,
It's
yes.
a fantastic question there. Which part to scan? Normally, when we have minimal air in the pleura, we were taking an X-ray, sending for X-ray. And for when minimal air was there, we had to turn the patient laterally so that the air comes to that area and take an X-ray. Whereas in an ultrasound, it is very clear, if you keep the patient supine, all the air will come up towards the superficial aspect. As a result, if you scan just the anterior part, when it is minimal, it is very easy to see the lung point, which Amit highlighted, where there is you can see the lung sliding, and where it is stopping. That lung point can be easily seen when minimal pneumothorax is there. It is more sensitive, said to be more sensitive than a CT or ultrasound, because you have a quick on the patient side analysis.
And one more question about the phrenic nerve palsy. I want to plan a study with the low volume supraclavicular block. I am a big fan of supraclavicular block. I do everything like shoulder and everything with a supraclavicular block. I really don't too much fancy an interscalene block. So what I was wondering was how to scan the phrenic nerve involvement with the various volumes of the drug. Now we have come down to at times 10 ml, and 15 ml is routine, and we are trying to come down to 10 ml. So just wanted to assess the phrenic nerve involvement, but really don't know how to assess the diaphragmatic movement objectively so that you can really document and say that, yes, it is different. Because a couple of times that I tried scanning, in fact, the diaphragmatic movement increased. So maybe the patient cooperation was different before the block and after the block. So how to eliminate this bias and make it more objective?
There are published articles with assessment, so you can look at it. But what I can, what we practice is always on the other side is our rescue. The normal side. We have done a block on one side, so we have to assess on the other side. So the two parameters which we are assessing for diaphragm is diaphragmatic excursion and diaphragmatic thickening. It has a little bit of this thickening aspect. Previously, when we used to assess it, we used to put probe anywhere and wherever we could see and get image. But now we are more objective and we are placing it on those areas. And so now if anybody else is doing, say, diaphragmatic excursion, they are putting the probe same place. I mean what I have explained with the mid clavicular and the anterior axillary line, and for the diaphragmatic excursion. So there are defined areas, and always comparing on the other side and documenting it. I think
Yeah.
anybody
On the other side,
Vandana madam, if I may,
on the
like
side,
Amit said
the block.
about this, we are just there's just a new article in RAPM this month, and it's about dose response relationship between local anesthetic volume and hemidiaphoretic paresis following US guided supraclavicular brachial plexus blockade. I think that is a question you're looking at, so you might
correct.
that,
Yes.
Okay.
article.
I'll look up the article.
I think we
take
are
a few questions.
done with the yeah, I think we are done with the questions. Anything
Yeah, a couple of questions.
I have one question for Amit. Basically, I was waiting to go and get an opportunity. Amit, I liked your presentation very much. I just wanted if you could show us a few things when you have done an ultrasound guided. Like sometimes in ICU we get these loculated pleural effusions where you use ultrasound to find out the pleural effusions and tap them. So what is your experience about that?
I'll tell you the recommendations, because I have done it, but it was not on very regular basis. I am mainly inside the operation theater, but once or twice when I was called. So the recommendation is you can use a curvilinear probe or a phased array probe for diagnosing it. But when it comes to needling, it is good idea to use a linear probe.
Right.
You got my point. I have done it with a phased array. We had one patient who had landed up with severe pericardial tamponade and thing like that, and we want to puncture that area. So it is very difficult with a phased array probe and other probes, but putting a linear probe would solve it.
And
So
since you talk about tamponade, like even for pericardiocentesis also you can use the ultrasound
yes
to guide your needle for that, right?
Yes.
Yeah.
Subbu,
Yeah, a few questions.
you have a question to.
Yes.
Yeah. There are two questions. Can we have a still image of the gastric antrum?
Yes.
And is gastric ultrasound helpful in the case of pyloric stenosis or hypertrophy?
Fantastic. I'll answer both of them, Ritesh. The first question is, how to take a still image?
Yeah.
Next time, I'll take this feedback and put it in my video, what buttons to press on. But it is fairly easy. What we need to do is, when we have got the ideal position, identified all the landmarks, and we're getting the picture, you freeze the image.
Yeah.
Once you have freezed it, almost every machine has some kind of calipers on it. So you can use those calipers. The calipers could be a linear measurement in terms of length or cross-sectional area. You choose one which has got a loop or ellipse sort of a thing, or a free trace tool. One is freezing. If you just want to save, you can save that. But once you freeze, you can activate your image or your calipers and use it to measure the cross-sectional area. It is possible, fairly easy.
Maybe you
if
can ask the
can,
patient to hold breath for a second, and then you can feel the breath.
yes, that also.
Yeah.
And sometimes in obese patients, no, where in which I have found if they take a deep breath, it will push the liver will push the stomach
Right.
down, make it easier, and hold it at the deep inspiration. That also.
Exactly.
Yeah.
And the other thing is about pyloric stenosis and hypertrophy. The number of pediatric articles have been published to say how to diagnose pyloric stenosis or hypertrophy, ultrasound images. You don't need to do any other, advanced investigation. They have a specific way of diagnosing. It is possible to do.
Yeah. Okay. I think it's time we have considered all the questions. It's time to wrap up. Thank you to all the three speakers. It was just exceptional talk. And I think
Thank you.
all the delegates must be telling wow, nothing else. It was just wow. Thank you,
Thank you. You
Himjatida.
made our day.
Thank you, Amit.
Thank
Thank
you.
you, Subbu. It
Thank you all.
was just amazing. And thanks to all the delegates. I think I don't have the exact numbers, but I think there were around 2,000 viewership. Okay, roughly 2,000 viewership. Exact numbers Rahul will tell me. And the delegates who have logged in, there is a Google form in the link itself. Kindly fill up the Google form and you can download the certificate of this webinar from our AORA website. Any person who has, any delegates who have logged in our earlier webinar, they have not downloaded their certificates, they can go to our AORA website and they can download their certificates. Uh, Thank you, the speakers. Thank you, Harshal. Thank you, Arnanshu, for moderating the session very nicely. Thank you, President Ma'am. Thank you, my aura, for giving me an opportunity of holding this webinar, monthly webinars. And I hope I am standing to your expectation. Thank you, Film. Thank you, Rahul, from Anesthesia TV. He has been, for last 1 month, he's working on it. And it was just a beautiful webinar. And see you all next month with a new topic. Till then, goodbye. Stay safe. Take care, because we are seeing uh, another second wave. So please take care of yourself and be safe.
Thank you
Bye-bye.
very
Good
much.
night. Take care. Bye-bye.